In our next keynote speech, our speaker is going to elaborate on how AI is introduced and applied in health and Medicare field. Ladies and gentlemen, please welcome Mr. Chuan Lee, Dean of College of Medical Science and Technology, TMU. Sir, please.
Okay, I'm glad to be here, and I'm very happy. I took a quick look around the exhibition before I came in, and I see a lot of startup companies. How many of you are involved in a startup company or are thinking of having a startup company? Can you raise your hand? Okay, great, thank you. I hope that my talk actually give you some idea if you want to start a new startup company, because you know about AI. It's the new sexy words. Myself, I'm actually a dermatologist, a skin doctor, but then I took a PhD in computer science, so it's kind of a go astray, and then I came back. So anyway. It's a $1 trillion market, and nobody would deny that. And based on some of the predictions, people are going to lose their job. Okay, among these people, analysts, physicians, okay, lawyers and teachers. Hopefully, some of our ideas will make physicians work easier, and maybe some of them lose their job, but they could go and find a better job, right? Okay, so. The MIT professor, Eric Brynjolfsson, he talked about the triple revolution. So we used to use mind. Now it's the time for the machine. Okay? We used to sell product, but now it's time for platform. We used to hire a small group of people, a core group of people, to develop our core technology, but now it's the crowd. So. And this AI hype is actually a historical thing. Everything started, I think, in 1950-something. And then we had the first AI winter. When I was in the US in 1991, I was, in for the second AI winter. At that time, nobody wanted to talk about AI. So if I go to a professor and say, can I learn AI from you? You will say, no, I'm not doing AI at all. I'm doing decision support, I'm doing model feeding, but no, I'm not doing AI, okay? It's kind of a dirty words back then. But then it all started with image. I think some of you already know the story of ImageNet from Google, and also people also attribute the credit to Professor Li Feifei. So the ImageNet actually spawned a very a lot of revolutionary thinking, and people got interested in image again because of the, if you haven't heard the story, one team actually broke the barrier of 60% accuracy in terms of recognizing random images from the internet. And that team achieved 80% using, now we know, as CNN, or convolutional neural network. But actually, AI is not just machine learning, okay? It's also rule-based inference, probabilistic inference, statistical modeling, ad hoc scores, and of course, the most modern, the most popular algorithm is machine learning, and it's all part of ANN. It's all a different shape of ANN. So you see a lot of deep neural learning, deep neural network, deep CNN, DCNN. Even AlphaGo uses DCNN to win this game. This is the second ranked Go player in the world from Korea, and the first ranked Go player from China. Okay, so basically, human would never think about winning a Go chess from the computer anymore, because AlphaGo actually, they actually developed another version of AlphaGo called AlphaGo Zero, who beat AlphaGo, I think, 10,000 games in 10,000 games. So humans are, forever. And also, it's not just chess. AI can also bluff, right? In this Texas poker game, it's more a kind of a cheating, bluffing, mind game. But AI also beat human in this kind of game. So it's not just a lot of calculation and computation, and because the computer computes fast, so it wins. Also, AI can also master bluffing, lying, in a sense, better than human. That's crazy. So it's not just recognizing, as you can see that the demo outside, you can see things like this. This is from YOLO 2. AI can go beyond just recognizing overlapping object. It will also tell you, in the future, what the dog is thinking about, okay? And, what the car is doing. Is it parking there or it's gonna go? So it's not just recognizing anymore. Okay, that's, I'm just trying to tell you, in terms of medical knowledge, there are very simple rules that can be quite useful in medicine. Like, if your patient is allergic to penicillin, that's antibiotics, and the doctor prescribed penicillin, then the computer should say, okay, be careful, the patient is allergic to penicillin, you're not supposed to do it. That doesn't require a CNN or deep learning. It requires a simple rule, right? If patient is allergic to penicillin and the doctor prescribed penicillin, then stop it. So it's a simple rule, but there are also complex things like this. Okay, this is from one of my patients who suffered this problem on his back for 10 years. And I wonder what that is. It took us a while to figure out. We asked him history and a lot of other things. But then I thought, why don't I just upload it to Google Image and see what Google said, right? And then Google said it's radiation dermatitis. And it was right. I was actually quite surprised that Google was right about this diagnosis. Because this patient did suffer from radiation dermatitis. He had a catheter, a 心导管, a heart catheter done, and it requires a high energy radiation video camera. So he suffered from radiation dermatitis since then. But Google doesn't even know the history, and it gives you a correct diagnosis. So I was very surprised, actually. It took us a while. Then I think, okay, how about I upload another image, which is kind of an old image, low resolution, and it's not very clean. As you can see, there are bare sheets and everything. So I uploaded this image to, and this Google tells me it's nominal dermatitis, and it was right. So I was thinking, okay, maybe dermatologist is not going to last very long after this 2 tests. Okay, lucky for me and for us, I upload another 10 images and none of them were right. Okay, I'm only showing you the right ones. Okay, but who knows? Maybe next revision. But it's only the beginning. The image. So a lot of people are thinking about image applications in healthcare and medicine. Okay, that's fine. It's a good direction, but it's also a very competitive direction. So it's not just image, and there are many, many different types of images from healthcare that you can get. For example, radiology images, nuclear images, sonograms images. These represent different kind of resolution, different kind of purpose, different kind of signal strength and noise ratio. Endoscopy image, angiogram video, so we also have video, not just images. And also pathology and dermatology photos. And pathology photos tend to be a very high resolution photo. They could go as far as like 4,000 by 4,000 pixel per image, okay? So higher dimension images, that's probably in the future, medicine, in healthcare, we no longer need images because images are for human eyes to recognize. So if we use AI to read images, why do we need images at all? They're just a bunch of data, right? It's a bunch of high density pixels with, for human eyes to recognize, we limited the grayscale of each pixel to 12 because human eyes can only tell the difference between 12 grayscale. But if it's AI which is reading it, there's no limit to how deep a pixel can go. And there's no limit to how many pixels can go in an image. So we're no longer talking about an image. It's probably a cube of high density data that's going to be the future of diagnostic images, or not even images, okay? So, and the second thing is free text. There are talks about, there are a lot of study about long short-term memory recurrent neural network, or LSTM-RNN, that could actually handle free text pretty well. And IBM Watson for Oncology is also one of the examples that free text, especially medical free text, are processed and created into this knowledge base. So we have been quite successful in free text, but not actually successful enough. One of my colleagues, they're doing Twitter analysis. So Twitter is a short message of 140 characters. They're using Twitter message to look at who has drug addiction, okay? And who has side effect from specific drugs. So these relies on free text processing. And biosignals, we measure a lot of biosignals of our patient. Electronic cardiogram, electronic encephalogram, which is from the brain, electronic muscular gram, which is from the muscle. So a lot of ECG, EMG, EEG, EXG, these are continuous biosignals. Pulse oximeter, these measure your pulse and also the oxygen concentration in your blood. So imagine that a patient goes to a hospital and stay in the ICU, and we put on ECG or sometimes EEG on the patient, how much data it's going to collect. And the sampling rate is about 3,000 times to 1,500 times per second, okay, per second. And we have the patient stay in the ICU for a week. Imagine how much information it's going to generate. It is generating every day, okay? Except that we did not make good use of it. We throw them away mostly. We look at the monitor and the ECG were beeping, but we did not store the data before. Now most hospitals are trying to store all the data and waiting for you, new entrepreneurs, to find a way to analyze it and value add to them. And also coded data. Actually, Taiwan probably has the best coded medical data in the world in terms of population and the length of time we have. We have 23 million people's data, coded, standardized data for 23 years. So 23 million people, 23 years. Every data are coded and standardized, the whole country, one standard. So imagine, how much value you could actually dig out of this data. I'm still trying to convince the government that we should open that data set, okay? It is currently in a clean room, meaning if you want to go access the data, you have to barely, you can barely bring anything with you. Maybe your clothes, that's okay. You don't have to be naked, but you pretty much have to be totally clean out of all the electronics to go into the room and use the data and only bring the result out. You cannot bring the raw data out. And it has severely limited the utility of the data set. And also temporal dimension, we haven't fully addressed temporal issues. So if you ask people who do prediction or temporal-based, time-based analysis, you'll find out time is still a very pesky dimension. It's still pretty difficult to analyze. So if you want to start a business using AI in healthcare, I suggest that there are 4 topics that are very good, and we really need help from new thinking, new entrepreneurs. The first area is medical errors. Okay, and then poor and inconsistent quality. One-size-fits-all approach. And then prediction and prevention. Okay, in Chinese, I kind of translate them into, 医疗错误、品质不佳、以偏概全 and 忽略预防. Okay, so these are kind of negative things, right? In terms of medical error, we think hospital is a place where we should be saving patients. But the fact is, in the year 2000, cause of death, in terms of the top 5-10 cause of death, medical errors kill about 98,000 people every year in the US, and it ranked number 5 in the top 10 cause of death. Okay, after 16 years of effort, trying to make patients safer and everything, the US managed to kill only 251,000 patients per year by mistake, and it ranked number 3 right now in terms of the top 5 cause of death. Why, you ask? Are we stupid? We're not bloodthirst. We don't want to kill patients. So why are we killing more patients every year when we are trying to prevent them? Okay, one of the reasons, of course, is the complexity of medicine is growing exponentially. There are so many different people, and then there are new drugs every day. The inflation of medical knowledge is at a rate of 50% per 17 months, meaning every 2 years, the useful knowledge, if I graduate from the medical school 2 years, the useful knowledge, the knowledge that I have, only 50% useful. And after 10 years, imagine how many percent are useful? None of them. That's why it's so easy to make a mistake, and it's very complex. And of course, patients are vulnerable. That's why they are called patients. So there are a lot of errors that we're making. So there are a lot of room to improve. We should be able to stop many of the mistakes. Actually, the WHO, the World Health Organization, made a vision. They created a vision this year, and they swear in 5 years they're going to cut down 50% of medication error, which is part of the medical error. Giving wrong drugs to people, taking different wrong dosage and stuff like that. And it's still over the news every, now and then. Okay, and quality is not good too. Based on a large-scale study, 45% of the people did not get recommended care. Not the highest quality care, but just average care. People don't get it. And this is for adults, and it's published by New England Journal of Medicine like about 15 years ago. My friend from Australia just published another paper about the quality of care for children in Australia, of course, but it kind of applies here too. They got the same low quality. About 45% or 50% of the children also did not get the quality care that they deserve. So the quality is bad, okay? And we made a lot of mistake. And if it's in a cartoon, that means it's true, right? So let's look at the cartoon. So the doctor says, it seems like we have a mix-up with your test result. And Dilbert says, oh, great, so I'm not dying, right? And the doctor says, we doctors are amazingly smart. We're super smart. But occasionally we make a little error, right? Okay. And Dilbert says, oh, I understand. The doctor said, by the way, your pap smear was normal. Okay, pap smear 就子宫颈抹片了. Okay, so another mix-up. Okay, so if it's in a cartoon, it must be true. Also, the third problem is what I call one-size, well, actually a lot of people call it one-size-fits-all problem. It's the imprecision in medicine. When you go to the hospital, you're no longer a patient, you become a disease, a diagnosis, a symptom, right? Because we treat people with the same diagnosis the same, which is totally wrong. For example, well, the diagnostic accuracy, for example, if you go to a doctor and they give you a diagnosis, 20% of the time they're wrong. And this is the lowest that I've reviewed. Some says 40%. Okay, so only 20% were wrong. And if you look at the lab data range, okay, if you go check on your liver function, you all work very hard, right? In Chinese, we call it, you consume your liver, 爆肝, right? Or explode, your liver explodes, or something like that. So you go check your liver function, and there's a normal range, 0 to 40. Okay, if you're 39, yeah, congratulations, you're fine. If you're 41, no, bad function. But imagine that a 10-year-old girl checking liver function and a 90-year-old, 80-year-old man also check the same liver function, and they use the same normal range. Does that make sense to you? You don't have to go to medical school to figure out that's wrong. That's very wrong, actually. But that's how it's practiced today. And we really need AI to make sense of it, because we don't deserve it, right? We don't deserve a diagnostic error that big and so imprecise in medicine. And a lot of information, of course, also missing. Allergy information, we did a study, 40% are missing. Family history, 90% are missing. And family history is a very important proxy for genetic information. So before you check genetic information, family history is the next best thing. Not to mention that genomic, behavior, and environmental data are not available to doctors. So now you think so many data are missing, and we are only making 20% error. That's not too bad, right? Okay. So doctors are super smart, So this is one of the efforts to help improve diagnostic accuracy. Human Diagnosis Project, they collect about 600,000 cases, and they try to discuss the right diagnosis. So the last issue is prevention, okay? But prevention is easier said than done. People always say prevention is important, one stitch in time saves 9, blah, blah, blah. 预防胜于治疗. But, prevention is very hard because, first, there's no visible target. How do you know you're successful in prevention? Because nothing happened. So I'm successful, right? But, it's a kind of success that's really hard to measure. It's repetitive and it's slow. So you walk 10,000 steps and you eat 5 different kind of vegetables for 3 days. It's kind of tired, right? And nothing happens, so why would I keep doing it? And there's no pain. Prevention is not because of pain. You want to prevent that from happening. So there's no pain to tell you need to take the drug. And people don't understand probability. If you tell people that, if I said, okay, all of you are gonna die, I'm 100% accurate. I just didn't say how long, right? So after 100 years or 500 years, right, all of us are gonna die. But that's not very useful. So science can produce, before science cannot produce reliable or useful prediction. That's why it has a very low market value. This is kind of a voice transformation right now, right? Okay. Anyway, can we have another microphone? This sounds funny. It has a low market value because if I tell you you need to spend $100 a day to prevent disease from happening, but if you have a disease, the government pay for you to treat your disease. You're saying, why would I prevent? Well, just let it happen, right? So it's very difficult to do this prevention thing. We developed a model to predict cancer, specifically liver cancer. And we have several different models. So imagine on the day that a person is diagnosed of cancer, the prediction will be 100%. It's not even prediction, right? But if you go back 1 month, it become like 85%. 2 months, 84%. So we were able to predict cancer with an accuracy, we refined it, the model, with an accuracy of 88% 1 year before the cancer happened, hepatoma or liver cancer happened, because most people are having a 爆肝 issue. So liver cancer is very prevalent in Taiwan, unfortunately, because we are an area that we used to have very high hepatitis carriers and patients. So it's important to predict. Why is it important to predict? Because when we are diagnosed of cancer, we change our life, right? We exercise every day full time, and then we eat organic food, and then we think happy thought, and we go to karaoke and sing a lot. Why don't you do it 1 year before you're diagnosed? Maybe you won't get it, right? So it's important that we predict and we prevent. So I'm just going to show you some ideas that could possibly be the AI solutions for our healthcare problems, which I spend a lot of time talking about. We need background lifetime data surveillance. So whatever data we have, we need a background lifetime data surveillance. And surveillance means monitor and alert, okay, and actionable alerts. Okay, not just telling you you're abnormal, that's useless. It has to be actionable, meaning this is abnormal, so you should do this and this to prevent that from happening. And we really need a lot of smart summarization and visualization, because the sheer amount of data a doctor is encountering, that create more errors. If you look at a patient, patient's electronic health record, and it took 30 minutes to look at the whole records, how much time do you have to diagnose the patient? And just-in-time diagnosis and treatment advice. This is a little bit like, Watson is trying to do the treatment advice. And disease or adverse events prediction, prevention, or early intervention, meaning disease prediction, I already gave you an example. Adverse events, meaning things that should not happen, but still happen in a hospital or in a healthcare system. Like, for example, a diabetic patient, a patient with diabetes, should not be giving an IV of sugar, right? We call it D5 water. This is dextrose, 5% dextrose. So we should not give diabetic patient this sugar in the IV drip. Sometimes it happens, and AI should be able to capture that event and prevent that from happening. So these are the data that we're looking at. In a hospital, we look at patient profile, we look at lab data, diagnosis and problem, medication and procedure. So these are the 5 major type of data that we look at. But actually, when we're talking about AI in healthcare, we're looking at more than just 5 categories of data. We're also looking at genotype, and the 5 categories are phenotype, meaning you already exhibit that. And exposure type, that's the environment. Okay, so what's the PM 2.5 today? What's the humidity today? What's the temperature today? It all change your susceptibility to diseases, and also your behaviors, of course. If we can collect all this data along with time, from the time you're born to the time to now, then you get all the input variables for AI in healthcare, right? And what would be the output variable? Okay, the output variable could circle around the clinical events, and there are several different types of clinical events, including treatment, diagnosis, management, rehabilitation, and prognosis. So if we can do the detect the clinical event before it happens, then it's prediction, right? If we detect the event the moment it happens, we call it early detection. And then afterwards is suggestion and recommendation. So So if you want to do an AI application in healthcare, these are your output variables, and the previous slide are your input variables. You can take all of them, some of them, you can output some of them or all of them as you see fit. So AI in medicine, when we start, we think, men are gonna lose their job, bad. Okay, so machine is greater than men, right? And then people say, no, it's not gonna happen, humans are smart. So then people say AI should not be artificial intelligence, it should be augmented intelligence. So human plus machine works greater than human. Everybody say, oh yeah, that's the right solution. That's all we need, right? But when I think of it, in mathematics, you kind of cancel them out. So human become obsolete, right? And the computer will rule the world. There's something wrong with my math. Anyway. And we also established something we call MHI, or Artificial Intelligence for Medicine and Health Innovation, in Taiwan. And so it's not just artificial intelligence in the center. There's also a small print for artificial empathy. As you can see, empathy works. Is the weaving threads among our healthcare services. If you only provide very smart healthcare, but without empathy, humans don't take it very well. Say, yeah, if you're a doctor and you tell your patient, sorry, you have 14 days to live. Okay, your 1 year survival is 10%. That's very cruel, and most patients will say, yeah, I will find a different doctor, right? So you have to be very careful, how to express your empathy. Same as AI. AI also needs to know how to express its empathy. Okay, so we don't have a lot of time already. So, conclusion: AI is gonna revolutionize medicine, and it's coming really soon. No matter what it does, it will going to change our work profoundly. And I'm always asked about a question: who's gonna lose their job first, right? And as a dermatologist, my answer is, I don't know when are we going to lose our jobs as a dermatologist, but I know it's after radiologists and pathologists. Okay. 当放射科医师跟病理医师都失去工作，就换到我们了，皮肤科医师。So really, but this sounds like a sci-fi story, but it is true that these two specialties, especially radiologists, there are very few doctors who are willing to work in radiology right now. So, but I think that's, future are mutable. So let's see what's going to change it. And let's hope for a better healthcare future with AI, because we deserve it. Thank you.
Thank you, Professor Lee. Thank you very much.